Heart disease is not a sudden event. It is the final stage of a long biological process. Years before chest pain, before blocked arteries, before abnormal stress tests, subtle internal metrics begin to decline. These changes are measurable but rarely felt. The cardiovascular system is highly adaptive. When early dysfunction begins, the body compensates. Blood vessels constrict slightly to maintain pressure. The heart pumps a little harder to preserve output. Hormonal systems such as adrenaline and angiotensin increase to stabilize circulation. This compensation hides the problem. During this silent phase, three core physiological metrics begin to deteriorate: endothelial function, insulin sensitivity, cardiorespiratory fitness. Each of these reflects a different layer of cardiovascular health. Endothelial function determines how well your blood vessels relax and regulate blood flow. Insulin sensitivity determines how much inflammatory and metabolic stress is placed on the vascular system. Cardiorespiratory fitness reflects how efficiently oxygen is delivered and used at the cellular level. That is, when these three metrics decline together, vascular aging accelerates, arterial walls become stiffer, inflammatory signaling increases, oxidative stress damages the inner lining of vessels. Plaque formation becomes more likely. Importantly, this can occur while routine blood tests still appear normal. Heart disease does not begin with blockage. It begins with dysfunction. Silent metric 1. Endothelial function. The endothelium is the thin inner lining of every blood vessel in your body. It is not just a passive barrier. It is an active endocrine organ. Healthy endothelial cells release nitric oxide. Nitric oxide allows arteries to relax and expand. This maintains smooth blood flow, stable blood pressure, and proper oxygen delivery. When endothelial function begins to decline, nitric oxide production decreases. Arteries become less flexible. Vascular tone increases. Blood pressure gradually rises. This is one of the earliest measurable changes before heart disease develops. The primary drivers are metabolic and hormonal. Chronic elevation of insulin damages endothelial cells through inflammatory signaling. High glucose increases oxidative stress inside the vascular wall. Elevated LDL particles can penetrate the endothelial layer more easily when nitric oxide signaling is impaired. Cortisol also plays a role. Persistent stress increases sympathetic nervous system activity. This promotes vasoconstriction and reduces endothelial repair capacity. Over time, small areas of endothelial injury appear. The body attempts to repair them. If inflammation remains elevated, plaque formation can begin at these sites. Importantly, endothelial dysfunction often occurs years before visible arterial blockage. It is functional decline before structural damage. Early indicators may include rising resting blood pressure, reduced exercise tolerance, or subtle changes in vascular stiffness. These changes are often dismissed because they do not cause pain. Reversal is possible. Improving insulin sensitivity reduces inflammatory load on the vessels. Regular aerobic activity increases nitric oxide production. Resistance training improves vascular elasticity. Adequate sleep restores hormonal balance and supports endothelial repair. When nitric oxide signaling improves, arterial flexibility can partially recover. Silent metric 2. Insulin sensitivity. Insulin sensitivity determines how efficiently your cells respond to insulin. When sensitivity is high, small amounts of insulin move glucose into muscle and liver cells efficiently. Blood sugar rises moderately after meals and returns to baseline quickly. When sensitivity declines, the pancreas must release more insulin to achieve the same effect. This is the beginning of insulin resistance. Insulin resistance is not only a blood sugar issue, it is a vascular issue. Chronically elevated insulin increases inflammatory signaling. It stimulates sympathetic nervous system activity and promotes sodium retention in the kidneys. This raises blood pressure gradually over time. High insulin levels also promote the production of small, dense LDL particles. These particles are more likely to penetrate the endothelial layer, especially when nitric oxide signaling is already impaired. At the cellular level, excess glucose increases the formation of advanced glycation end products. These compounds stiffen arterial walls and damage structural proteins in blood vessels. Mitochondria inside endothelial and cardiac cells become exposed to higher oxidative stress. Reactive oxygen species increase. Repair mechanisms weaken. Importantly, fasting glucose can remain within normal range during early insulin resistance. The body compensates by producing more insulin. This means metabolic decline may be progressing silently even when standard screening tests appear acceptable. Early signs may include increasing waist circumference, rising triglycerides, mild elevation in fasting insulin, or difficulty maintaining energy stability between meals. Reversal requires improving cellular response to insulin. Resistance training increases muscle glucose uptake independent of insulin. Aerobic exercise enhances mitochondrial density, reducing excessive refined carbohydrate intake, lowers insulin demand. Adequate sleep improves hormonal regulation and reduces cortisol-driven insulin resistance. Restoring insulin sensitivity reduces vascular inflammation and protects endothelial function. Silent metric 3. Cardiorespiratory fitness. Cardiorespiratory fitness reflects how efficiently your body delivers and uses oxygen. It depends on heart output, lung capacity, vascular flexibility, mitochondrial density, and muscle oxygen extraction. When this metric declines, the heart must work harder to deliver the same amount of oxygen to tissues. Early decline is subtle. Resting heart rate may gradually increase. Exercise feels slightly more difficult than it did a few years ago. Recovery time becomes longer. These changes often go unnoticed. At the cellular level, reduced cardiorespiratory fitness means lower mitochondrial efficiency. Mitochondria are responsible for converting oxygen into usable energy. When mitochondrial density declines, oxidative stress increases. Oxidative stress damages endothelial cells and cardiac tissue. It accelerates arterial stiffening and promotes inflammatory signaling. Lower oxygen efficiency also reduces nitric oxide availability. This further impairs vascular flexibility. Hormonal balance is affected as well. Low physical conditioning is associated with higher baseline cortisol and reduced growth hormone response. This shifts the body toward catabolic dominance. Tissue repair slows, vascular recovery weakens. Importantly, low cardiorespiratory fitness is one of the strongest independent predictors of cardiovascular mortality. It often predicts risk more accurately than cholesterol levels alone. The key difference is this: cholesterol reflects circulating lipids. Cardiorespiratory fitness reflects systemic functional capacity. One is a number, the other is a measure of biological resilience. Improving this metric is highly responsive to intervention. Structured aerobic training increases stroke volume of the heart. Mitochondrial density rises with consistent conditioning. Resting heart rate decreases as autonomic balance improves. These changes directly reduce cardiovascular strain. How to reverse the 3 silent declines heart disease develops when dysfunction remains uncorrected. The advantage of these 3 metrics is that they are modifiable. Endothelial function improves when nitric oxide production increases. Regular aerobic training stimulates shear stress along vessel walls, which directly enhances nitric oxide synthesis. Resistance training improves arterial compliance. Adequate sleep supports endothelial repair through balanced growth hormone release. Reducing chronic hyperglycemia lowers oxidative stress within the vascular lining. Insulin sensitivity improves when muscle glucose uptake increases. Resistance training is especially effective because skeletal muscle can absorb glucose independently of insulin during contraction. Increasing lean muscle mass lowers baseline insulin demand. Reducing excessive refined carbohydrate intake prevents chronic insulin elevation. Managing sleep and stress reduces cortisol-driven insulin resistance. Cardiorespiratory fitness improves through progressive cardiovascular conditioning. Moderate intensity steady-state training enhances mitochondrial density. Interval training increases stroke volume and oxygen extraction efficiency. As conditioning improves, resting heart rate decreases and autonomic balance stabilizes. This reduces chronic sympathetic stress on the heart. These 3 systems are interconnected. Improved insulin sensitivity reduces endothelial inflammation. Better endothelial function enhances oxygen delivery. Higher cardiorespiratory fitness lowers metabolic strain. When addressed together, vascular aging can slow significantly. The key insight is this: Heart disease is rarely the first event. It is the endpoint of declining function. If you measure and protect endothelial health, insulin sensitivity, and cardiorespiratory capacity, you intervene years before structural damage occurs. Prevention is not about waiting for blockage. It is about preserving function before the system fails.